All right, well, welcome everyone. My name is Dr. Tala'at Al-Shuqairat. I'm a pulmonary critical care physician from Provo, Utah. And I am joining today Dr. Ron Balkissoon from National Jewish, talking on the role of pulmonologists in infectious disease prevention. So we're excited to share this with you. Our presentation is structured differently. We will have two components. In the first part, I will go over a couple of case studies that hopefully will set the stage for Dr. Balkissoon to talk more on the role of, on the impact of infections and respiratory diseases and exacerbations, as well as the role of vaccination. And this is here my bio and disclosures. I'm a pulmonary critical care specialist. I work with Revere Health in Provo, Utah. I'm a clinical adjunct assistant professor at the Norda School of Osteopathic Medicine. So this presentation is sponsored by GSK, and I will start with my first case presentation. So first case, this is a 65-year-old female patient and has history of COPD. She has history of significant smoking, diagnosed at the age of 60 with history of chronic bronchitis and dyspnea and exertion. Her spirometry from March 2023 confirms the diagnosis of COPD with an FEV1 at 80% of predicted and decreased FEV1 FVC ratio. And based on her symptoms, she's Gold Group B, grade 1, which means that there is no history of severe exacerbations or had maybe one moderate exacerbation over the last 12 months. Currently, she is on a long-acting muscarinic antagonist, which is appropriate. And patient has been doing well up till April of 2023, when she had a COVID-19 infection and had an acute COPD exacerbation that was treated at the time with oral corticosteroids. On June the 3rd, 2023, this patient presents with ear pain, and at a local clinic, she was diagnosed with otitis externa. Topical antibiotics were prescribed. However, over the next week, there has been no improvement in her symptoms or fever, and started to have discomfort on the left side of the face and jaw. She started to have a low-grade fever. And now this is my first interactive question. So what do you think the immediate next step should be? Should we start oral antibiotics, start patient on acetaminophen and oxycodone, order CT of the sinuses, or perform excisional biopsy of the temporal artery? I'm hoping there are answers coming, so I can't see those answers yet, but all right, perfect. Well, the right answer is acetaminophen and oxycodone, because this is the most appropriate next step here, because patient does not have a definite infection to start oral antibiotics. There's no suspicion for sinusitis clinically, and definitely not a candidate yet for excisional biopsy of the temporal artery. Presentation is not suggestive of that. So patient visited the emergency room the next day. This time she has this rash. There was, in addition, progressive severe pain, mild dyspnea, and rash on the right ear and jawline. So take a look at this, and examination. This showed maculopapular erythematous eruptions, sensitive to touch over the left face. There was no hearing impairment on that side. And this will get us to the second interactive question. So at this point in time, what do you think is the likely diagnosis? Impetigo, cellulitis, atopic dermatitis, or herpes zoster? right, perfect. So the correct answer is herpes zoster. Patient had further evaluation in the ER. She had mild leukocytosis and PCR positive for varicella zoster virus DNA in the vesicular lesions. So this presentation here is typical for herpes zoster infection. Test of choice is PCR. Results come back in 1 day or less, and it is the test of choice. So that's what this patient has. So management of herpes zoster. Patient treatment plan was to start patient on oral antivirals. So if patients present within 72 hours, we treat them as such with an antiviral agent, valacyclovir, 1,000 milligrams twice daily. There is a role for treating if it's past 72 hours, if patient has an immunocompromised status or older patients, and then IV, sometimes opioids for acute pain management, and oral analgesics. So this case here is actually important for us because that's not something that we deal with on a day-to-day basis as pulmonologists. However, this patient is a patient who's actually, typical for the population of patients that we see on a daily basis. This patient has COPD, was treated with steroids, and herpes zoster is definitely a complication of steroids treatment in that population, especially with the fact that they're middle-aged, they're older. If you look at herpes zoster, it affects 1.2 million patients a year as per CDC data. And it's about 50% lifetime risk for getting zoster. However, if you look at the most important risk factor for zoster, it's actually age. And being immunocompromised, like for example, giving steroids, does increase the risk for that. So this study here, this kind of case, brings up the attention to herpes zoster as a complication of the treatment that we often give to patients with obstructive airway disease with steroids, and we do use steroids for other conditions. So this patient developed an illness that actually could have been prevented, and we will talk about that here in a few minutes. So patient was treated properly, her lesions improved. However, a month later, she started to have more problems. She started to have persistent pain on the site of the rash, and gabapentin was prescribed. Further evaluation and follow-up revealed that this patient continued to have pain on the site of the rash that persisted for more than 3 months, and patient was diagnosed with post-herpetic neuralgia. Patient was referred to neurology for further management and was treated for that. So this patient then developed a complication of zoster. So not only that she had herpes zoster after she was treated with steroids for her COPD exacerbation, but she developed the most common complication after zoster infection. Most of the time, patients do well, but in about 10 to 15% of patients, they can develop post-herpetic neuralgia. Now, there's quite a few things that can happen as well with herpes zoster. They could have, zoster ophthalmicus or oticus, or sometimes even aseptic meningitis or encephalitis. But the most common is post-herpetic neuralgia, which is quite a disabling illness. Patients will present to you with, they may present to us, but they often will present to their primary care physician, and they would have pain at the site of the previous rash that's quite disabling sometimes. And the risk factor for that is actually age. And older patients, as we become, as our T-cell immunity decreases with immunosenescence, 50% of those patients are above the age of 60. So this case here is important because it actually should raise the awareness that we can actually precipitate herpes zoster infections. And then at the same time, when we treat for exacerbations, for example, with steroids, and then that illness can actually have significant morbidity. And what's important is that this infection can be prevented with a vaccine, and vaccination against herpes zoster can actually decrease the incidence of post-herpetic neuralgia, even if patients had herpes zoster infection. And the importance of this is that the population that we deal with on a daily basis is a population that actually is at risk for this. So when it comes for COPD management, this patient was continued on LAMA, and that was the proper management. That was her first exacerbation. So my second case study presentation. So this patient here is 70 years old, a male patient with history of COPD. This patient presents with fever, cough, and dyspnea. He's an ex-heavy smoker, diagnosed with COPD at the age of 55. No known allergies. Spirometry done in March 2023 showed confirmed obstructive airway disease, moderate in severity. Chest X-ray showed hyperinflation. This patient, per GOLD report, meets Group B and Grade 2 definition. Current COPD medication treatment is LAMA and a LABA combination in dual therapy. This patient had most likely had one moderate exacerbation or none over the last 12 months, and he is properly on dual therapy for a Grade 2 MMRC. Now, this patient presented in October with sore throat and fever, and he was diagnosed with an upper respiratory tract infection at a local clinic. Antipyretics were prescribed. There was no improvement in the sore throat, continued to have myalgia and cough, and then presented to the ER the next day. This time he's not doing well. He's hypoxic. Resting oxygen saturation is 80% on room air. He's tachypnic, has fever. There's evidence of increased work of breathing. Lung examination shows diffuse bilateral crackles and bronchi. Patients continue to deteriorate and then ends up being intubated. This is a representative chest X-ray, bilateral infiltrates, widespread leukocytosis, and then throat swab with PCR testing came back positive for RSV. Diagnosis is this patient has a lower respiratory tract disease due to RSV infection. Patient was placed on mechanical ventilation, antipyretics, IV fluids, IV steroids, and nebulized bronchodilators. Blood cultures were negative for strep. And then 1 week later, he actually improves, and patient was extubated and discharged home for 3 days. Now, why do I present this presentation or this case? This case here is important because this is a patient who has COPD, who was doing fine, and then this patient developed an exacerbation. As COPD severity, increases, patients are at high risk for exacerbations. But in a significant portion of those patients, exacerbations are due to viral infections, including RSV. So this patient had actually an exacerbation with a viral infection that could be prevented because we could have vaccinated this patient against RSV, given the fact that we have vaccines for RSV. And this patient would qualify because they're approved for patients above the age of 60. And because of RSV, there was significant morbidity. He had significant risk for dying. Luckily, he made it. But what this actually represents is a lot of patients that we take care of that can end up with severe exacerbations, and their risk for exacerbations in the future will be significant just because of the fact that they had a recent exacerbation. This patient was a week later discharged. It's a very common patient that I'm sure all of us has taken care of. And then he was extubated and discharged 3 days later on home oxygen. Now, this patient was discharged, and he was discharged on triple therapy. So obviously he was on dual therapy, and because of the fact that he had a severe exacerbation, this patient ended up or should be continued on triple therapy to prevent further exacerbations. And the question that comes is, what else should we have done for patients like this? How often do we actually think about vaccination in patients with COPD exacerbation if they've actually had a viral infection that could be prevented? That can include, obviously, influenza now, COVID, as well as RSV. These two case presentations shed a light on a new aspects of care that we need to assume as pulmonologists. We often treat COPD in terms of management of symptoms. We kind of manage their exacerbations, whether they're moderate or severe, but often we don't really think much about vaccination. And vaccination falls into two folds here. The first one is the fact that we need to vaccinate patients to prevent them from having respiratory illnesses. And obviously there's 3 at least illnesses that now we can vaccinate for. We can vaccinate for influenza, for COVID, and for RSV. The second thing is that we don't think much about vaccination for zoster, herpes zoster, for example. And the issue that actually COPD represent, in my opinion, is the fact that COPD is a systemic disease, but we have not really assumed the leadership role for managing COPD. We often just address the treatment. treatment of symptoms, treatment of exacerbations, but we don't really treat the disease in a holistic way. And vaccination would fall into that. So I think I finished like 10 minutes earlier than my allotted time, but that will give us more time for questions. I think this case will set the stage very well for Dr. Balkissoon to go over his data. I'm going to finish here with a last question that I kind of technically answered. What vaccine-preventable disease would you have considered preventing in these patients prior to disease presentation? So choose all that applies. Perfect. So it's actually all of the above. So now we have the options to vaccinate against herpes zoster, COVID-19, influenza, pneumococcal disease, RSV, and pertussis. And actually, when you go through GOLD report, you'll find that these actually have been recommended in GOLD. So Dr. Ron Balkissoon will discuss in the next section, in the next part of the presentation, the burden of vaccine-preventable diseases in COPD and asthma patients. I will turn the stage to him.
Welcome, everyone, and thanks so much. And thanks to Dr. Al-Shuqairat for doing such a wonderful presentation with two clinical scenarios that help us to understand the increased risk that patients who have chronic lung disease are at in developing a number of respiratory tract infections, part of it because of structural changes in the underlying lung itself with COPD and asthma, but also the fact that many of our patients are on immunosuppressive therapy, whether it's systemic or oral, systemic or inhaled corticosteroids. So that being said, what I'm going to try and go over is what is the relative contribution of a variety of different types of viruses and their impact in patients who have COPD and asthma. So next slide, please. This is just my biography and disclosures. Originally from Canada, did all my training between University of Toronto and McMaster. I have a master's in clinical epi as well. Wore many hats or have worn many hats at National Jewish, and I continue to see patients there. I'm on staff at National Jewish Health and largely see patients who come from out of state, a number of them who have significant COPD and asthma. Next slide, please. I should also mention that I am sponsored by GSK to give these types of talks. So next slide, please. All right, so what we're looking at here is we're looking at the relative contribution of viruses and allergens and their ability to cause exacerbations in patients who have COPD and asthma. The purple numbers represent the numbers for patients who have COPD, and the green represent those for asthma. So on the left-hand side, you can see that respiratory bacterial infections, about 26 to 81% of exacerbations may involve some type of respiratory bacterial infection. And also there's with seasonal and temperature changes, we also know that there's a 2 times increased risk of acute exacerbations of COPD as well. When you look at the sort of asthma numbers, obviously we know that a large proportion of people who develop asthma develop in childhood, have significant allergy issues. And so we say that greater than 80% of children are sensitized to allergens and that can lead to exacerbations. Also, when you look at respiratory viral infections in the asthma population, we think that 6 to 85% involve viral infections, 22 to 64% of patients who have COPD may involve respiratory viral infections. And then if we look at things like adherence and poor treatment adherence, about 24% of exacerbations may be attributable to poor adherence to medications and other types of preventive measures. Next slide, please. So this is just going over for us the relative contribution of respiratory viral infections in COPD and asthma. If we look at the left-hand panel, you can see that respiratory viral infections are detected in up to 22 to 64% of COPD exacerbations and 60 to 85% of asthma exacerbations. And the most common viruses are influenza, RSV, human rhinovirus, and coronavirus. And what are the consequences? Well, we know that COPD exacerbations that are related to viral infections have more severe clinical course and than the non-viral associated exacerbations. So you see problems in terms of longer hospitalizations, increased lung function decline, so a more rapid decline in their lung function over time, and obviously increased symptom severity. It's also interesting that we know that patients who might have a virus infection, that increases the susceptibility to developing bacterial infections. So it may be priming, increasing mucus production, further compromising the lung, and may lead to a superinfection with a bacterial infection on top of it. Next slide, please. So RSV in particular, we know can exacerbate COPD and asthma. It's been detected in about 10% of the acute exacerbations for COPD. And for an acute, in a prospective study where they looked at older and higher risk adults, RSV accounted for about 11.4% of hospitalizations for COPD and about 7.2% of hospitalizations for asthma. Next slide, please. When we look at influenza, it also has a significant contribution to acute exacerbations of COPD. A retrospective study that was done that showed the prevalence of respiratory infections, including influenza virus, was the second most detected virus. Rhinovirus was the most common detected, but it was 22.5% for influenza in cases of severe acute exacerbations of COPD. And then there was another study of about 4,700 hospitalized COPD patients. About 38.5% of them tested positive for influenza illness. And those who had the influenza infection had higher rates of crude mortality. You can see the numbers there, and needs for critical care, both of those being statistically significant. And for patients who have pre-existing chronic lung disease, the hospitalization rates due to influenza per year were 13 per thousand in adults aged 50 to 64 years and 23 per thousand for those who were over the age of 65. And so we know that age, there is a factor there. Dr. Al-Shuqairat made reference to immunosenescence, that as we get older, our immune system becomes less efficient, less capable to help fight infections. And so there is that factor of age really being critical in looking at the group who are at greatest risk. Next slide, please. So I think Dr. Al-Shuqairat did a wonderful job in explaining what's the relationship, why are we even talking about herpes zoster? Well, I think the case that was presented shows the impact, the associated morbidity with patients who develop herpes zoster, the post-herpetic neuralgia and other types of problems that even after the acute event can have quite an impact on the quality of life for our patients. And I think it was a very important point that was made up, that our patients are often immunocompromised, even if it's the inhaled corticosteroids, but certainly a number of our patients who are on oral corticosteroids frequently are at increased risk of developing herpes zoster. So you can just look at the figures there, 41% increased risk of herpes zoster in patients with COPD, gives you the relative risk. That's in a meta-analysis in 12 different studies. And if you look at 124% of increased risk of herpes zoster in patients with asthma, and you can see the numbers there as well. And as I said, we do think that the risk of herpes zoster in the patients with COPD may be further increased by their systemic corticosteroid use. And I do think I think Dr. Al-Shuqairat made a very nice point about this is where it falls into our arena. We shouldn't necessarily be thinking, oh, that's something that we need to pass on to the primary care physician to take care of. Something that we can own, and we can try to make sure that we know the risks for our patients because of the medicines that they're on, and that we should perhaps be proactive in trying to get them vaccinated. Next slide, please. So here's I think a very nice slide talking about pneumococcal disease and invasive pneumococcal disease and pneumonia. And what this is looking at is it's breaking down, allowing us to look at what is the increased risk of exacerbations according to age, and those are the different colors. So the light pink, that's for those 18 to 49. The orange is between 50 and 64 years. The darker orange is greater than 65 years. And the gray those gray boxes represent the relative risk. And then on the bottom, we're going across from left to right to a variety of comorbidities, and noting that as you look at these different comorbidities, they impart a greater risk of developing exacerbations. So for those who have no comorbidities, you can still see that there's a signal according to age. As we go across the spectrum from diabetes, chronic heart disease, smokers, alcoholism, asthma, and chronic lung disease, which includes COPD, of course, you can see that graduating increased risk, the relative risk of having significant exacerbations as we go from these different comorbidities and as we look across the age spectrum. So helping us to understand those patients in our practices who are at the greatest risk of invasive pneumococcal disease and hence would warrant thinking about immunizing them for this. And just in the left-hand panel, you can say an increase in mortality was observed in hospitalized patients who had COPD and pneumonia compared to hospitalized patients with COPD alone. So obviously developing that pneumonia imparts greater morbidity, greater mortality. So anything that we can do to prevent that is a great bonus to our patients. Next slide, please. So when we think about the treatment or management of patients who have chronic respiratory conditions, we often focus on symptom relief and management. So on the left hand of this panel, you can see the things that are really about symptom relief with regard to bronchodilators, inhaled corticosteroids. These are maintenance therapies to try to help to reduce exacerbations and improve symptoms. Antibiotics in that acute setting, mucolytics is also important. And these are all agents that we use really that are for symptom management. When we think about and including pulmonary rehabilitation. I should have mentioned that, of course. And then on the right-hand side, we see three key features that are prevention strategies, which are avoidance of aggravating factors, whether it's managing comorbidities or trying to reduce exposures like air pollution and those sort of things for people. Smoking cessation, of course, is key and critical. And then also vaccination is, I think, a very useful way of trying to prevent significant morbidity and mortality for our patients who have chronic respiratory disease. Next slide, please. And so when we look at what are the foundations of a treatment plan for COPD, there are these four different components. So obviously we talked about smoking cessation and avoidance of noxious stimuli. That's incredibly important, obviously. Real challenge with many patients, but getting them in smoking cessation programs is really key. I think that vaccinations can have a critical role in the different scenarios that we outlined through Dr. Al-Shuqairat's presentations. I think that plays a critical role as well. And obviously exercise rehabilitation, often underutilized, underappreciated, but study after study after study shows the benefits. And obviously trying to get patients involved in exercise and rehabilitation programs can be extremely useful on a number of different fronts that I'm sure you're all aware of. And then, of course, pharmacotherapy, both rescue and maintenance types of therapies are critical as well. Next slide. Here are just some tools that have been distributed or at least published by the Centers for Disease Control and Prevention with regard to adult vaccination. They include, the CDC, according to the CDC, immunization provides the best protection against vaccine-preventable diseases. There's this adult vaccine assessment tool. There's the standards for adult immunization practice, and there's the CDC cooperative agreement with the Council of Medical Specialty Societies. These are great references to learn about the importance and the value impact of immunization programs. Next slide. And Dr. Al-Shuqairat made mention of the fact that both GOLD and CDC fully endorse the vaccinations for influenza, COVID-19, pneumococcal vaccination, tetanus, herpes zoster, and RSV, that these are all recommended for patients who are at increased risk of COPD. So, and asthma for that matter. So, but this is really, we're talking about in this one, obviously looking at the GOLD guidelines, but also looking at CDC. So when you see the spectrum of vaccinations that can be used in this patient population, when we understand the fact that our COPD patients, our asthma patients are at increased risk because of the immunosuppression, partly because of functional and structural changes in their lungs, but obviously also in part because of the medicines that we give them that compromise their local and systemic immunity, that we probably should own and really think about, if we have the facility to do so, to vaccinate our patients for these various diseases, which clearly we see have an impact on the outcomes for patients that we take care of with COPD and asthma. And so I think that with that being said, between the cases that have been presented this afternoon, and as well going over these recommendations from the from CDC and GOLD, that there is a role for the pulmonologists in actually owning and taking care of some of our patients with regard to these issues, or if not that, making sure that we have the discussion with them to understand the importance of them getting these vaccinations, if not in our own offices, then through pharmacies or other types of facilities that offer these types of vaccinations. Next slide. So I would just like to say thank you all so much for joining us this afternoon, and I hope that we've been able to present a very cogent argument, or at least a rationale for why not only should we be urging our patients to have these vaccinations, but even perhaps own it and see if we can't set up in our own offices the ability to be able to deliver these types of treatments or maintenance therapies or prevention therapies for our patients who have COPD and asthma. And so I think we're going to look and see if there are any questions that come up. But I think in the interim, what we were going to do was just entertain a couple questions and start with a discussion between Dr. Al-Shuqairat and myself. So, Dr. Al-Shuqairat, I was just wondering if, you could tell me what do you think are the major barriers to patients with to doctors or pulmonologists in being able to deal with patients who have COPD and asthma and doing vaccinations?
Well, I think, to me, I think I think there's a problem with us kind of assuming a leadership role, like I mentioned earlier, and like you kind of referred to, like we need to own this. To me, I think COPD falls into the same category like diabetes. It's a systemic disease. It is really. There's so much into COPD that sometimes we just don't really focus on because we think primary care will take care of it. So, like vaccination is one of them. So for example, diabetes, primary care do take care of all the aspects of diabetes, checking for, albuminuria, checking the eyes, doing eye exam, assessing their cardiovascular risk. But COPD, on the other hand, is the same thing. COPD, there's a significant increase in risk for coronary artery disease. There's increased risk for osteoporosis. Like, how many pulmonologists do DEXA scans? We don't do that, right? I mean, we don't do that regularly, although we should, right? And I think partly because we think that primary care should do that, and then primary care think that the specialist is doing this. And I really think it falls on us as pulmonary doctors for doing this. So vaccination is kind of important because a lot of the issues that we struggle with in terms of like exacerbations and the worsening outcome and the known data on increased risk for morbidity and mortality with exacerbations, we don't really do a good job of the vaccination, and I think we should assume that. One thing that I try to kind of change in my practice is, other than obviously screening patients for the last time they've had a moderate or severe exacerbations, if there's anything that happened over the last 12 months, is making sure that they're up to date with the flu vaccine, COVID vaccine, and nowadays RSV vaccine. We have not been doing a good job with the zoster. So it's different, but most of our patients are above the age of 50, and we can give that to them. In fact, even for those who are immunocompromised between the age of 19 and 49, they can qualify for the zoster vaccination, because we can sometimes, without really realizing this, we can increase the risk for having a zoster and increased morbidity and with the infection. I think the barrier is kind of like assignment of roles, and I think it falls on us that we should take that leadership role. We just make it like a regular practice to not only making sure that the inhalers are being used correctly and they're on the right regimen and they're following guidelines, and we know about the exacerbations, but working on prevention as well and managing the other comorbidities of COPD the way endocrinologists and primary care manage diabetes. And I think this is something that we have not done really as pulmonologists. What do you think, Dr. Balkissoon? I mean, what do you think? How can we actually communicate, our concern when it comes for, that there is a risk, and then how important the vaccinations are to our fellow pulmonologists?
Well, I think, yeah, I mean, that's a good point because I think part of it is about addressing and helping to educate our pulmonary colleagues, and then there's also the issues of trying to have that communication with the patients as well. Well, I mean, I do think even in our presentations, we've brought up the points that we can share with our colleagues who probably just don't have an appreciation to the extent to which vaccination could help to prevent significant exacerbations and consequences for our patients who have COPD and asthma. And I think that to that point, seeing if they don't even have at least the facility, if they don't have the facilities in their own office to be able to do it, that they are indeed passing it on and helping to make patients aware of the importance of these vaccinations. And even, if we're not set up in our consultation notes to our colleagues, like their primary care physician saying that, because of the reasons that we've outlined, we do think they would benefit from this list of vaccinations, reinforce that by saying that both the CDC and GOLD have recommended this list of vaccinations for our patients who have COPD. And I think that that's actually been quite helpful that we now have this endorsement by both GOLD and CDC that our COPD patients in particular should be receiving this list of different vaccinations. I think it's instructive in illuminating why we think that herpes zoster vaccination should be given to our COPD patients, understanding the fact that they have a certain amount of compromised immunity related to their underlying disease process, but also that we're often using medicines that compromise their immunity. So I think that those are the things that I try to now incorporate into our practice. We do have the ability to do a number of these vaccines on site, some of them that we don't at my institution. So we have to make sure that we can tuck those in. So I think we have a really a leadership role because of we take care of these patients and their underlying COPD, understand the importance that vaccination plays not only in preventing exacerbations of their underlying lung disease, but also complications and exacerbations of other disease processes they can develop as a result of the immunocompromised state that they have. So those are the kind of things that I think of. What about you?
I'm just like reflecting the same way too. Like I'm just thinking like sometimes, I mean, we do this all the time. Like you have this patient coming to the office, frequent exacerbations, he's on the right treatment, he's on triple therapy, you've contemplated, roflumilast, you've even considered azithromycin, to prevent exacerbations. And although this is not recommended, but I think there's still some folks out there using chronic steroids to prevent exacerbations when we never really think about maybe preventing the infection, right? Like decreasing, I can't wait for the day when we have data on, how does actually vaccination decrease exacerbations? And I think it should, because as you mentioned, there's clearly few etiologies that are preventable, right? So there got to be an impact on exacerbations. Like RSV, when I talk to my patients who come in and they kind of like questioning, vaccine, how patients sometimes have, may have different views on vaccination. But when I say the RSV that your grandchildren have when they come and give you a hug that can give you an infection, where they're kind of more willing. So I think a lot of it is education on our end as pulmonologists and educating our patients. And I think the impact of that will actually be good, even like from a value-based care, like, decreasing hospitalization, decreasing, ER admissions. I think it will be really nice to have data on how vaccination can actually alter those parameters and then, kind of, impact them better than just giving medications. Like we're thinking of prevention rather than treatment, which is a change of how we practice medicine, right? I mean, it's a different concept, right? Especially for us, because we never really do this regularly.
Right. And I do think that every time we see a patient who's either been sent back to see us because they had an exacerbation or we ended up taking care of them for their exacerbation, affords us an opportunity to pass on to their primary care physicians and or internists that, this is something that could have been prevented, this person ending up in the ICU, if we thought about vaccination, and then just endorse, the fact that the patient should be vaccinated to help prevent any additional events, and then also take the opportunity to talk about the things like herpes zoster that also our patients would benefit from being vaccinated. So anytime I have that window or opportunity where patients had a recent exacerbation, I think it's an opportune time to pass on to their other providers the value and importance of making sure that they're being optimally vaccinated, and throwing in that this is something that's endorsed and really promoted by the CDC and GOLD guidelines.
No, I fully agree. Dr. Balkissoon, any kind of final remarks?
Well, first of all, thank you for your excellent presentation. Appreciate and great working with you again. And to our audience, I'd like to say that I hope that you found this session instructive.